Okay, we'll go ahead and get started. My name is Kristen Thomas. I am an ED clinical pharmacist. I practice in Toledo, Ohio, and today I'll be talking to you about medical management of ACE-induced angioedema. I have no disclosures regarding this presentation. By the end, I'd like for you to be able to do three things: discuss the pathophysiology of how ACE-induced angioedema occurs, describe the treatment options that we have in the ED, and also assessing the appropriateness of medication management of ACE-induced angioedema. Angioedema is a very common presentation that we see in the ED. It's estimated that there is a lifetime prevalence of either angioedema or urticaria of about 25%, and this does result in more than 1 million visits to the ED each year in the United States. It is mediated by several different mechanisms, the most common being a histamine-mediated angioedema, followed by bradykinin, and then very rarely pseudoallergic or idiopathic. But no matter what type of mechanism it is, correct diagnosis is very critical because obviously any type of angioedema can progress to severe upper airway compromise and even death. I know that this image is a little bit hard to see, but on your left we have a depiction of a histamine-mediated angioedema, which is a type 1 IgE hypersensitivity reaction. So this results in the mast cell degranulation. This is in response to a previous sensitization to a drug, a food, or an insect sting. On the right, we have a depiction of the kinin-kallikrein system. Now, this is a system that's not totally understood, but it does involve hormonal aspects as well as the complement system. So as you can kind of see, factor 12 starts the cascade, where we have a conversion of prekallikrein to kallikrein. That then converts kininogen to bradykinin. And so we get the accumulation of bradykinin, and that's what results in the angioedema. There are some distinguishing characteristics that can help you determine whether it is a histamine or a bradykinin angioedema. Histamine, as we just discussed, is an allergic response. Almost 99% of the time, a patient will present with urticaria if it is a histamine angioedema. If it's bradykinin, they're likely not going to have that. Histamine angioedema also occurs very quickly compared to a bradykinin, typically within several minutes, up to 2 hours. Bradykinin angioedema can develop very slowly over hours to days. And very importantly, histamine angioedema will respond to the conventional treatment, the epinephrine, the steroids, and the antihistamines, whereas a bradykinin angioedema will not, simply based on the pathophysiology. So briefly, there are 3 types of bradykinin angioedema. The first is hereditary angioedema. So this is a problem with the C1 esterase inhibitor. And what this does in the body naturally, it interferes with that kinin-kallikrein system. So C1 esterase inhibitor will decrease the production of bradykinin. In somebody who has hereditary angioedema, either they have a mutation so that the inhibitor doesn't work, or we have enough, or we don't have enough of it. So acquired angioedema, typically diagnosed later in life, and over half of these patients have either a hematologic or an immunologic component of their angioedema. And lastly, what we'll be discussing today is the drug-induced angioedema, specifically ACE inhibitors, but keep in mind that there are other medications and other classes that are commonly associated with angioedema. ACE inhibitors, as we know, are widely prescribed for a variety of indications, most commonly hypertension, heart failure, and diabetic nephropathy. The common adverse effects that we think about are hyperkalemia, dry cough, and a transient increase in serum creatinine, and much less commonly, angioedema. However, ACE inhibitors are the leading cause of drug-induced angioedema. The incidence overall is pretty low. It's about 0.1 to 0.7% annually. However, this does account for 30% of all angioedema-related ED visits. So if you haven't seen it yet in your practice, you will. Up to 16% of these patients require intubation. Up to 1% require a tracheotomy. And there is a very high rate of hospitalization that is associated with ACE-induced angioedema, up to 66%. So this is a pretty, you have to think about the cost of this as well. And because we are increasing our prescribing of ACE inhibitors, the prevalence of angioedema is obviously going to increase as well. This can happen to anyone, but there are several risk factors that are associated with ACE-induced angioedema, including being older, female, Black or African American, a positive smoking history, having that ACE-induced cough, and also a previous angioedema, whether or not that's related to an ACE inhibitor. So the pathophysiology of the ACE inhibitor involves both the RAS system and the kinin-kallikrein system. So a brief review, we have renin-converting angiotensinogen to angiotensin-1. ACE comes in and converts that to angiotensin-2, which is the bad guy that results in the vasoconstriction, the production of aldosterone, and the increased blood pressure. On the right, we have another review of the kinin-kallikrein system, the kininogen being converted to bradykinin. Normally, ACE is going to break that down into the inactive metabolites. However, if we have an ACE inhibitor, then we get the accumulation of the bradykinin, and we get the vasodilation, the vascular permeability, and ultimately angioedema. By definition, angioedema is a swelling of the submucosal or the subcutaneous tissue. Specifically for an ACE-induced angioedema, this is typically an asymmetric, non-pitting edema, usually involving the face, the lips, the tongue, larynx, pharynx. It can be seen in other areas, less frequently in the extremities, and also in the abdominal viscera. So this would look like nausea, vomiting, diarrhea, and maybe even ascites. And similar to other bradykinin angioedema, ACE-induced will also develop very slowly, typically over hours to days. Now, when a patient walks through ED triage, we obviously don't know, we can't point at them and say, well, this is a histamine versus a bradykinin angioedema. So the first step is always going to be to assess and secure the airway. Then we can start looking at other factors to help us distinguish if it is a histamine versus bradykinin. So we're going to review the initial symptoms. Did the patient present with urticaria? Determine the time of onset. Did it happen 10 minutes ago? Did it happen yesterday? Assess the past medical history and family history. So does the patient already have a documented history of hereditary angioedema? And then lastly, review the current outpatient medications. I'm always going to be looking for ACE inhibitors, but keep in mind that there are other medications and other classes associated with angioedema. So let's say that we do have a patient, they present with asymmetric angioedema, and you see that they are on an ACE inhibitor. What are our treatment options? Unfortunately, there's no FDA-indicated approved treatment for ACE-induced angioedema, but we have some options that are used for hereditary angioedema. So we'll be talking about each of these briefly. Keep in mind that the first three are extraordinarily expensive, and they are not always widely available to all EDs. The first is C1 esterase inhibitor, or Berinert. This simply replaces the C1 esterase inhibitor that we would naturally have. So it inhibits factor 12, it inhibits that kallikrein activity. The ultimate purpose of it is to stop conversion of kininogen into bradykinin. So it is FDA indicated for attacks of hereditary angioedema, dosed at 20 units per kilo IV, and for an 80 kilo patient that comes out to about $11,000 per dose. So it's very, very expensive. And the common theme with all of these is that we don't have a lot of evidence to support its use in ACE-induced angioedema. Specifically for C1 esterase inhibitor, this is very limited to case reports and case studies. So I chose a couple just to highlight. The first case on the left is a 63-year-old male on an ACE inhibitor. He presented with edema of the tongue, uvula, floor of the mouth, and the soft palate. He did receive the conventional treatment. The physician did not wait to see the effect of that conventional treatment and gave C1 esterase inhibitor within about 20 minutes of the patient arriving. It was noted that he had significant regression of his symptoms within 20 minutes of receiving the C1 esterase inhibitor and had complete resolution after 2 hours. Similar, the case on the right, this is a 41-year-old male, edema of the lip, tongue, and airway swelling, also received conventional treatment. This patient was intubated, and after he was intubated, he received a little bit higher dose of the C1 esterase inhibitor. It was noted after he got that, his swelling decreased, and he was extubated within 17 hours of presentation. So obviously, these case reports and case series are very limited. It doesn't give us a lot of robust data. So based on this and the cost, I might recommend it in my ED, but probably not. The second medication is ecallantide, and how this works is it inhibits kallikrein. So again, similar to the C1 esterase inhibitor, we're preventing the conversion of kininogen to bradykinin, so again, stopping that production. Also indicated for hereditary angioedema attacks. This is dosed at 30 milligrams sub-Q. You can repeat this dose within a 24-hour period. Cost for one dose about $17,000, so even more expensive than the C1 esterase inhibitor. And again, limited evidence for this indication. Again, there have been case reports and case series that look great. They give it to patients who are both intubated and those who are not, and they do have pretty quick symptom resolution. But in addition to those, Bernstein and colleagues conducted a phase 2 trial that looked at icatibant in patients who had failed conventional therapy. So the authors included patients who were adults taking an ACE inhibitor. They came within 12 hours of their symptom onset. They all received conventional treatment. So they all got the steroid, the antihistamine, and the epinephrine. And if they did not have symptom improvement within 2 hours, then they were randomized to receive either icatibant or placebo. The primary study outcome was achievement of discharge criteria within 4 hours of receiving that treatment. And this was defined as stable vital signs, no airway compromise, and a low level of edema in the mouth. The study groups were pretty equal. I'd like to point out that the majority of patients were African American, and also the majority of patients had a moderate severity of symptoms, and this was assessed by a blinded physician. And what the authors found was that icatibant was no better than placebo in patients being able to meet that discharge criteria. 31% of patients who received icatibant versus 21% of patients who received placebo, and this was not statistically significant. Of note, patients could receive an open-label dose of icatibant after an additional 2 hours, and a second open-label dose after another 2 hours. So as you can see, a lot of patients in both groups did receive an open-label dose. So this makes you think that the first dose, even of the study drug, really did nothing. So based on that, authors concluded there was no difference in using icatibant versus placebo. And because of that, I definitely would not recommend it for ACE-induced angioedema. The third treatment option is a little more interesting. So this is Icatibant. The way that this works is that it blocks the receptor. It blocks the effect of bradykinin binding to the B2 receptor. It is also indicated, again, for hereditary angioedema attacks. It does have off-label dosing for ACE-induced angioedema, which is unique. This is dosed like icatibant, 30 milligrams sub-Q. You can repeat this dose in 6 hours, total daily dose of 90 milligrams. Cost for one dose, again, not cheap at $13,000. And before I start talking about the phase 3 trial, there was a phase 2 trial that was published in 2015 that made icatibant look really good. So they had 27 patients. Patients received either icatibant or conventional treatment, so that was an antihistamine or a steroid. And patients did much, much better if they received icatibant. They had faster symptom resolution, and faster complete resolution. So it worked better and it worked faster. So using the results from that phase 2 trial, we went into our phase 3 trial conducted by Sinert and colleagues. And this was a phase 3 randomized double-blind, again to evaluate the efficacy of icatibant in patients who had at least a moderately or severe angioedema. Patients were included if they were adults and they had specifically head and neck angioedema, taking an ACE inhibitor. These patients could receive conventional treatment at any time, and over 90% of patients did receive the conventional treatment at some point. And these patients were randomized 1-to-1 to receive either icatibant or placebo. The primary study outcome was time to meeting discharge criteria, similar to the icatibant study, and secondary was time to onset of symptom relief. Again, the groups were pretty similar between the two, and again, majority of patients were African American. The authors found that icatibant did no better than placebo in this bigger phase 3 trial, which was a little bit of a surprise based on what we had found with the phase 2 study. So the median time to discharge criteria, 4 hours for both, and time to onset of symptom relief was actually better in the placebo group compared to icatibant. So authors concluded that icatibant was no more effective than the placebo, and because of that, I also would not recommend this in my ED. The last treatment option is fresh frozen plasma, or FFP. And the way that this works is that it provides an enzyme that is identical to ACE. So it provides kinase 2. This breaks down the bradykinin, and it breaks it down pretty quickly. FFP obviously not approved for any type of angioedema, and there have been several doses studied in the literature, but the more accepted dose is about 2 to 4 units. And one of the biggest benefits with this is the cost. So at my institution, it's about $50 a unit. If you would use the full 4 units, that's $200 versus the thousands and thousands of the former treatment options that we discussed. FFP is obviously a blood product. There are going to be pros and cons associated with that. I think the biggest pro is the inexpensive cost, but also it's very widely available at EDs. We don't always have those 3 previous treatment options available or on formulary, so this is something that's pretty easy to get. Cons, FFP blood product, you run the risk of infection, fluid overload, and there's also a theoretical chance of making angioedema worse. The way that this works is if the patient has hereditary angioedema that has not yet been diagnosed. So a hereditary angioedema is a complement-mediated process. If you give FFP, you are giving complement factors, so you could actually be making it worse. This is more theoretical, it hasn't happened yet, but something to keep in mind. So again, like the other treatment options, there are plenty of case series and case reports that support FFP for this indication. I've just chosen a few to highlight. So case 1, 73-year-old African-American male, on lisinopril, came in with swelling of the tongue and face. This patient received conventional treatment ×2, didn't get any better. In fact, his swelling worsened after 5 hours, and so he received 2 units of FFP. After getting that, within 2 hours, the progression of his swelling stopped. The patient was admitted overnight to the surgical ICU. By the next morning, complete resolution of his symptoms, and he left AMA. Case number 2 on the right is a 45-year-old African-American male on enalapril. Similar presentation, also received conventional treatment. After 3 hours, his lip swelling did continue to worsen. He got 1 unit of FFP, and within 2 hours, his swelling did stop, and the progression also stopped. So case series, case reports, they make us feel good, but they don't really provide a lot of evidence, right? So in addition to this, we have a retrospective cohort review done by Saeb and colleagues. And I really like this study because it was looking at much more clinical outcomes rather than meeting discharge criteria. So this compared the frequency of intubation and ICU length of stay in patients who had acute angioedema if they received FFP versus if they didn't. Keep in mind that this was not specific for ACE-induced angioedema. This was any acute angioedema, as long as the patient didn't have a documented history of already having hereditary angioedema. But if you look at the bottom, the baseline demographics, the majority of both patient groups were actively on an ACE inhibitor at the time. And what the authors found was very interesting. So patients who received FFP, 35% of those were intubated versus 60% of the patients who did not receive FFP. This was not statistically significant, but I would argue that it is pretty clinically significant. Also, the duration of intubation was lower in patients who received FFP versus those who didn't. The only statistically significant finding in this study was in the ICU length of stay. So patients who received FFP 1.5 days versus 3.5 days, and the overall total length of stay was also lower. Again, not statistically significant, but I would argue pretty clinically significant. So authors concluded that patients who had an acute angioedema who received FFP had that decreased length of ICU stay. But I think that we can get a lot from this study. Again, it's limited because the FFP group was such a small sample size, especially compared to the no FFP group. But because of this and my own personal experience with using FFP for this indication, this is my go-to treatment choice.
What was the dose in the Saeb study?
They didn't say. So that was a limitation. They did not report any of the units that they used, or if the patients received conventional treatment. So obviously fraught with limitations. So just to review where these fit into this picture, C1 esterase inhibitor and ecallantide essentially prevent the conversion of kininogen to bradykinin. Icatibant will block the receptor, so we're blocking the effect of the bradykinin. And then lastly, FFP simply acts as ACE in breaking down that bradykinin into inactive metabolites. So as I alluded to, at my institution, FFP is the treatment of choice for ACE-induced angioedema. We do stock C1 esterase inhibitor, but we reserve that only for patients if they have a documented history of hereditary angioedema. And I have to say that I have not ever used it since I've been working in my ED for any type of angioedema. So in conclusion, the prevalence of ACE-induced angioedema is increasing as we continue to prescribe more and more ACE inhibitors. Correct diagnosis is key because those conventional treatments of epi, steroids, and antihistamines typically won't work for ACE-induced angioedema. And for every single treatment option that I discussed, we don't really have a lot of strong evidence. So we do need prospective, larger randomized controlled trials to see which treatment is best. So at this time, I'll take any questions. Have time for maybe a couple. Yes?
I'm just curious at what time, I mean, you're obviously very comfortable with fresh frozen plasma. So you're seeing a patient come in, swollen lips, tongue, whatever, they're not intubatable yet. What time course and when would you abandon other things or start with fresh frozen? Where do you put it in your algorithm?
So the real world answer is that all of these patients are likely going to get the conventional treatment. I'm not recommending that you don't give it. I'm recommending you don't repeat it if it doesn't work. So really these patients are going to come in, we're going to get the steroid, the antihistamine, and/or the epi. If I'm looking and I do a med history and I see that the patient is on an ACE inhibitor, I'm recommending it immediately. I'm recommending they start FFP because, as you know, the process to getting FFP does take a little bit of time. It takes time to thaw it and actually to get it from blood bank to the patient. So I'm recommending it almost immediately. I have seen in my ED that there's some selection bias in who receives FFP versus those who don't. Usually the patients who come in with much worse angioedema right off the bat, providers are much more likely to order the FFP, whereas if a patient has just mild swelling, they're not going to. But it can progress, so I think that there still would be benefit to giving at least a unit of FFP. Yes?
Oh, quick question. So first off, do you have a Gestalt data set from your do you have a Gestalt data set from your experience as to the number of people that have hereditary angioedema that come to ER with angioedema versus the people with ACE inhibitors? Because to me, it's got to be 1,000 to 1.
Of patients who have hereditary
that
versus...
come to the ER. So I never see those patients. I see the ACE-induced angioedema.
Sure.
Is yours like 1 to 1, 10 to 1?
No. I have
1,000
never
to 1?
seen, we don't, in our community specifically, we don't have any hereditary angioedema.
Yeah, I never see it.
Right, but I did residency in Indy, so this is a little welcome home. But we did have at least one patient who would come in very, very frequently, and so and she used Icatibant, and so we had to, if she didn't have it, we had to make sure that we had that in stock. So I think it just depends on your community, but personally, I have not seen that in Toledo.
My follow-up would be, what's your dosing since there's no standardized dosing?
I usually start with 2 units. Any other questions? Okay, thank you.